Okay, so I'm Dr. Sohail Abrar from Taba Heart Institute, and this is a long topic, but I will try to finish in time. So if you go to the pericardial diseases, there are pericarditis, effusion, tamponade, constriction, restriction, so lot of things. I will touch upon the few things, and there is a overlap of the processes of inflammation and the fluid and scar, and the combination of these give these different presentations. So if we take a patient like young lady, no cardiac risk factors in the clinic, malaise, body ache, 2 weeks, and chest pain for 3 days, and it's not typical like I'm writing this because this is not the coronary artery disease, and there are some ECG changes and echo within normal limits. So this can be pericarditis. The pericardium we know very important structure covering the heart. Normal look is like this, but inflamed it may look like this, and then the next thing is that pericarditis you will not find, mostly you don't find anything in the echocardiography, but once they develop the effusion, then you start finding the things. And what is the pericardial effusion? It echo-free space is not always all the echo-free space are not pericardial effusion. So it may be circumferential, it may be incysted, and the small echo space during systole. So don't take it as a pericardial effusion. You have to take it during diastole, and you have to measure it during the diastole where sees clearly, and to grade mild less than 1 centimeter, moderate 1 to 2, and the severe more than 2 centimeters. This is the picture where how you differentiate. If you find a space here, that is the pericardial. If you find a space behind the aorta, then it is the pleural, and this is important to differentiate, and sometimes it may be difficult. The severity of the pericardial effusion you assess here, and you see that this here this you measure this thickness, and here you measure this thickness, and you can define the severity. Then she was started on not clinical diagnosis of pericarditis, started on treatment, but developed the shortness of breath and dizziness, and she was tachycardic, blood pressure low, and there was increased JVP and muffled sound. And we know clinically what's going to show the X-ray chest. This was the X-ray chest, and then because the patient is symptomatic and there's a large effusion we see, so we do the echo and we confirm your diagnosis. But we talk a little bit about the cardiac tamponade, and this is the clinical syndrome where the intra-pericardial pressure is higher than the intracardiac pressures, and it will compress and it will decrease the filling of the heart and the cardiac output. The tamponade depend upon how much is the fluid and how rapidly it is accumulating. If it's slowly accumulating, it will take time to develop, and it will be large fluid. But in acute settings, like the interventionists do perforation, if they get the perforation, a small fluid can give you the tamponade. And this is the pressure volume curve showing that if it is quickly accumulating quickly, then it will be like this, acute rise. If it is slowly, then the slow rise, and more volume is required. Then there is a concordance of intrathoracic and intracardiac pressure. This is very important to understand the pericardial disease pathophysiology. So when there is a change in the intrathoracic pressure during inspiration and expiration, it is transmitted to the intracardiac chambers, and there is no significant change in the velocities, mitral and tricuspid flow velocities. Normally this will happen. But when there is dissociation between intracardiac and intrathoracic intrapericardial pressures, like in case of tamponade, in case of constriction, then this dissociation will give you the pattern like during inspiration the mitral E wave decrease, and during expiration the mitral E wave increase, and same happens on the other side of the chamber. So this is the basic phenomena. If you understand this, then you can understand rest of the thing. So same thing is shown here. Due to interest of time, I will not stay here long. Same thing is ventricular interdependence is shown here, because When the ventricle cannot expand outward due to the fluid or thickened pericardium, this is the septum which shifts and which will change the inflow of the either ventricle and change the flow velocities. So this is the ventricular interdependence, and I will discuss it further. Then the important thing is that not always it is constriction restriction. So ventricular septal abnormalities you can get confused. Mitral inflow velocity variation due to various reasons, pulses paradoxes occur with increased respiratory effect. So all the diseases that produce an increased respiratory effect, effort like COPD, obesity, asthma, sleep apnea can give rise to this variation. So all the variation, they are not the constriction or tamponade. So cardiac tamponade echo signs, there are some early echo signs. Early is like IVC dilated non-collapsing, increased respiratory variation in mitral and tricuspid inflows. So they are they are early, they are sensitive, but late signs are RA and RV collapse, and very late sign where patient is critically ill, that the left side chamber collapse, and that's a very late sign. You can see here the RA collapse, you can see here. So this will look like this. RV collapse, very good picture you see here. The early diastolic RV collapse and late diastolic auric collapse. You can time with the ECG. Then on the M mode, you can easily, whenever you have to time, the M mode is a very good modality, and you can M mode it and you can time it. Definitely you need a ECG. So this is the variation at the transmitral Doppler, and there is variation of the E velocity with the breathing. Ideally you need a respirometer, but if you don't have it, still you can calculate it. This is the same thing on pictorial graph. The same thing will happen in the pulmonary vein, in the hepatic vein. So what happen pulmonary vein, mitral inflow, it will go to the pulmonary vein. To tamponade vein, there is similar thing. Hepatic vein Doppler you do, and you find the reversals, diastolic reversals. So you find these diastolic reversals there. You find the diastolic reversals there in the hepatic vein, and their timing can tell you, okay, what may be the diagnosis. I will further discuss. Then cardiac tamponade. So this is right heart chamber compression is specific but not sensitive for the diagnosis, because if the right heart pressures are already raised, then this compression will not happen and you can miss the diagnosis. 2D finding, the dissociation finding we already discussed, that is related to pathophysiology. They are sensitive and give the early diagnosis, and these changes are similar to those of constrictive pericarditis, except that septal E exaggeration is not seen. So the pathophysiology mimics, but the septum behave differently. Okay, so if you don't make the diagnosis, you know, okay, if you miss the tamponade, this will happen. Then the case 2, this is 55-year-old lady seen in the clinic with the history of pedal edema, dyspnea on exertion, abdominal distension for 2 months. Examination revealed markedly elevated JVP, pedal edema, ascites, and the echo is advised. And echo shows the biatrial enlargement, normal LV function, and restrictive filling. And the constriction versus restriction remained the major question in past, and we used to make a clinical diagnosis, but it is no more a dilemma, and there are things that can be done, and these are the things that are considered. But I'm going to show you that pathophysiology, I think I've discussed that this is a ventricular interdependence. Pericardium is thick and septum is free of disease, so it will give you ventricular interdependence. So for the sake of time, I move fast. Signs of features. What features we will look for? The signs of ventricular interdependence, any imaging modality, pericardial thickness, and condition of myocardium. So CT scan is good to show you the pericardial thickness, but we know that all the thickened pericardium will not give constriction physiology, and the normal pericardium can give you the physiology. And this is the thickened pericardium. And here the cardiac MR. Cardiac MR is a very good modality. it will give you all the things like the pericardial thickness, ventricular interdependence, and and the condition of myocardium as well. So this is a very good test, but limited availability and cost, we cannot use it all the time. Cardiac catheterization was used previously very often, but only one parameter, that is LV-RV interdependence, which has a very good sensitivity, specificity, and positive and negative predictive value. And this is an invasive test, and sometimes if you miss this finding in one go, then you cannot repeat it. The cardiac catheterization, you will see the restrictive cardiomyopathy, the pressure changes, go in the same direction, and in the constriction it will go, this is the RV pressure and LV pressures, they go in the opposite direction, that is ventricular interdependence. So this is important to find out these things, and you see this here as well. So echo signs of ventricular interdependence, septal shift with respiration, you see here, better visualized on this image. Okay, so with diaphragm you can appreciate the inspiration and expiration, and you see the clear septal shift. So it's a good image. Then we take the mitral and tricuspid E velocity variation. We take the hepatic Doppler vein, and we see the expiratory reversals in the hepatic vein. That's very good finding. This is the another thing. And additional echo features, we have to see septal bounce, and septal bounce is equivalent to cath finding of square root sign, and you can appreciate. Annular paradox, that the paradox is like the E to E prime ratio is normal and the filling pressure is increased, that is called annular paradox. Then you see here, and then the TDI, the mitral annulus, we have to see in the constriction and in the restriction. Constrictive, it is supranormal. Restriction, it is low, and that will differentiate. It's a very important parameter. And if you see the sensitivity, like different pathologies, constriction, amyloid, and primary restrictive cardiomyopathy, this is the cutoff of 8. If E prime is 8, more than 8, then most likely this is the constrictive pericarditis. So this is an important parameter. Then you can see the pericardial thickness here. You can measure it on the M mode. It's better to measure it on the M mode. And strain in constrictive and restrictive cardiomyopathy can be used. We have talked a lot about the strain. And because there is marked epicardial dysfunction in constrictive pericarditis, to lead to impairment of the circumferential and twist mechanics, where the longitudinal strain is well preserved in the constrictive pericarditis, but significantly reduce in the restrictive cardiomyopathy. Then these are the different things like consa strain kisme, like if you see the constrictive pericarditis, the longitudinal strain is normal, and the restrictive, it is decreased. Circumferential decrease in the constrictive and normal in the restrictive cardiomyopathy. Strain imaging, you can see in the restriction, the strain is well preserved. In the constriction, it is well preserved. The restriction, it is markedly reduced. Propagation velocity, we can see the propagation velocity. We don't do commonly. It's a very easy thing on the color Doppler you can do, and you can measure the propagation velocity if you have a slope caliper there. So you see here the steep at, I think we have another. Okay, so you see the slope of these thing. So it is constrictive pericarditis, very steep, and it is restrictive, it is very delayed, and they are reading that will predict that the constriction or restrictive cardiomyopathy. Then propagation velocity slope, same thing is here. And if you combine all the parameters of echocardiography, like like the hemodynamic Doppler, B is the 2D echo, and TDI, if you combine all these things, it's a very high sensitivity and specificity for the diagnosis of constrictive pericarditis. So tamponade versus constriction, we have already discussed in the previous presentation. I will skip this slide. These are the detailed differences between all these pathologies, both pathologies. Conclusion: pericardial diseases are common. It has a various etiology, clinical suspicion, and ECG is important. Echo is mandatory for the diagnosis, monitoring and emergency intervention. Whenever there is pericardial effusion, look for features of the tamponade. So Apart from कि कितना ज़्यादा है, it can be a small effusion, it can give you the tamponade. Constrictive pericarditis not uncommon in this region. Diagnosis of this treatable condition is challenging. Till recently, with the advancement of the echo technologies, no more a diagnostic dilemma. An expert can easily diagnose it. If clinical and echo findings suggest CPC, no further testing required. The CT people will argue on it. If there is discrepancy, then CMR is a useful modality. Thank you very much. हाँ जनाब. No, septal bounce is like square root sign. Sudden, like in constrictive pericarditis, early phase, the filling is brisk filling and the suddenly halt when it reaches a limit by the constriction of the pericardium. So sudden halt give you a bounce, and that will septal bounce. Same is in the cath lab, the square root sign equalization. So quick sudden equalization of pressure that will give you septal bounce.
Excellent talk, Dr. Sohail, and it was really comprehensive. One question, rather comment, जो कल डॉक्टर अयूब ने भी बताया था कि वो पेशेंट की अगर क्लिनिकल सस्पिशन नहीं है तो फिर बड़ा मुश्किल हो जाता है.
Sure.
जैसे कल वो टॉप का पेशेंट था और क्लिनिकल सस्पिशन ऑफ कंस्ट्रक्टिव पेरिकार्डाइटिस किसी ने बनाया ही नहीं. और सो क्लिनिकल साइंस आर वेरी इंपॉर्टेंट एंड आई थिंक इट्स वेरी इंपॉर्टेंट टू फर्स्ट डू द क्लिनिकल examination and take the proper history, and then when you make the clinical suspicion and you write down on the indication that this is the indication for the test, then maybe वो ज़्यादा अच्छी तरह से एको पे फिर देख सकें.
वो है डॉक्टर टीपू. बट if you are doing a comprehensive echo in a good lab, so there's so many signs that you cannot miss it. But if you are doing a casual echo and you don't have indication, definitely you are going.
Agreed.